My first question for both of you is, who are your patients today, and how has your patient profile evolved over time?
This generation of women has undergone a huge transformation in the way we build family. When I started in this field in 1984, the average age of first birth for a woman was 19. During this lifetime, my career, and the lifetime of my patients, it's gone from 19 to probably 35 or 36 in New York, 30 in the whole United States, which is more remarkable because 300,000 years ago, it was 14. It went 5 years and 300,000 years, and in this generation, it's gone 16 years. We weren't designed for that. Unlike Al Pacino can have a baby at 82, women were not designed to have babies in even their 30s and 40s. And we recognize that. So in 1999, we started freezing eggs in mice, so make sure we could do it well, because my daughter came here, I'd make sure that it was done right. And we did the only clinical trial. We did a free clinical trial in women who needed IVF anyway, and based on our mouse data, could tell them, we think it's gonna be as good. You don't have insurance, we'll pay for it. Let's see what happens. 23 patients later, we had our first baby 20 years ago. 57% of those women had a baby, expecting 50% if it was IVF. So we showed for the first time that this could be done. And because of that, we now have 20 years of experience, the largest experience of a single center, the most babies. We have over 400 babies from it. We have 46 women have their whole family from it. I just did a pregnancy scan on a 51-year-old patient who froze her eggs in 2012 yesterday. She's got a 7-weeker, but she already has an 8-month-old baby. She has her whole family from freezing eggs. I know it sounds crazy, but it's happening. I wouldn't have guessed we'd be 36 when I started in this field. So our team has really revolutionized it. And Sarah Cascante-Druckenmiller has been writing these papers. She gave an international webinar presenting our data because we are the place. And it's really a great, great team of people. But the other major breakthrough that we focused on is preimplantation genetic testing. Finding the healthy embryo that makes the baby. And in fact, when I was at Cornell in '92, we had the first baby from that. She's 33 years old now and does not have hemophilia, which she would have otherwise. And using that technology, we can select healthy embryos that reduce the chance of miscarriage. We put one embryo back at a time. The days of triplets and twins are gone, although twins happen still because an embryo splits. And we have 147 babies born for women who carry hereditable cancer genes, 50% chance their baby gets that gene. It's wreaked havoc on that whole family. And those babies don't have that gene, so their family won't suffer going forward. So really tremendous things, but we've gone from being fertility specialists treating infertility to actually 50% of our practice is egg freezing. And we now have 3 genetics counselors on our service. We're actually treating and preventing 558 genetic diseases. Babies don't have to be born with these diseases. And the best treatment is not having disease.
While Dr. Grifo's response is very positive and uplifting, unfortunately mine is not quite as positive and uplifting. I'm a GYN oncologist, so I take care of patients both surgically and through chemotherapy who have cancers of the reproductive tract. So in my field of cancer overall and in GYN oncology, the past decade has shown a dramatic increase in the number of patients who are diagnosed with cancers during their reproductive years. This has been most notable in colorectal cancers, number 1, breast cancer, uterine or endometrial cancers, which is what I treat, pancreatic cancers, and melanomas. So patients who need fertility support or consideration when they're diagnosed with cancer are growing. And unfortunately, I think they will continue to grow. That's the first change. The second is the technology that we have, that Dr. Grifo and his team have pioneered, have evolved considerably. While historically your options were egg freezing and sperm banking, now these have expanded substantially. You can now take ovarian tissue out of a young patient who has not undergone puberty and then reimplant it after they've been cured of their cancer, and then have them harvest eggs and reverse their menopause, which is something we do here at NYU. I did one last Monday. We're now enrolling in a trial where we take pre-pubertal testicular tissue in young boys, infants. We did a 6-month-old last Wednesday, and we send them so that in the future, this young boy who has leukemia and is going to have bone marrow transplant at 6 months can hopefully have sperm created either in vitro or in vivo sometime down the road. Surgically, we've had innovations, ovarian transposition, and most recently, uterine transposition for women who have non-GYN pelvic cancers who need radiation. We can move their uterus to the upper abdomen, let them have their radiation, cure them of their cancer, and then our team will do a quick procedure. It takes about an hour, reimplant the uterus back to its normal position, and they can then go on to have kids. Again, we offer that here at NYU. Third big change or evolution in our patients are there has been an increase in access to genetic testing, and this has been remarkable. We now have identified more genes that we know place a patient at high risk of cancers, and we now have broadened access to testing so that patients know early on if they're at risk for cancers. One of the highest risks we see is with reproductive cancers of the ovaries and the uterus, and so these patients need to have fertility support. That's really been the biggest changes in the patients that I see and that affect the oncofertility world.
When it comes to fertility preservation and oncofertility treatments, what recent advancements developed at NYU Langone have made the biggest difference for patients?
Well, since we started freezing eggs in 2005, that's been the most tried and true technique. Most of the babies are born from that, and we have over 40 babies of cancer patients who put their eggs in the freezer before they were cured of their cancer many years later, and that seems to work the best because we were able to do that kind of research. It's easier. Liz Fino on our staff, one of our residents and fellows, we have that mold, Sarah Cascante, the same. We get the best residents because of this medical school. We get the best fellows who come to and we keep them, and I'd send my daughter to any one of them. They're so great. Liz Fino got interested in this a long time ago when we started freezing eggs, and we've done over 1,700 egg retrievals and, 1,500 egg retrievals and embryo banking cycles for cancer patients. Those embryos are sitting right upstairs, about 50 feet that way, and their future babies, hopefully, when they're cured, they'll be able to have. So I think there are lots of opportunity for other methods, but right now, egg freezing is the most prominent and successfully used technique.
And what are the oncofertility treatments that you think have made the biggest difference for patients? And also, if you could explain just a little bit more, what exactly qualifies as oncofertility?
Okay, oncofertility is, it's exactly what it sounds like. When a patient's diagnosed with cancer or has a high-risk genetic mutation and they're in their reproductive years, it is either just the act of having the conversation with a patient. That is oncofertility. Many patients don't want to pursue fertility, but it is so important that they have the conversation and have that autonomy. If they do want to pursue fertility, it's offering them the treatments, navigating them through a quite onerous process that happens in a time where they have so many competing obligations. They need to start treatment. They need pre-chemo testing. They need pre-surgical testing. You all can imagine. And so that is oncofertility. It's the conversation and the actual tools that Dr. Grifo and his team and others offer patients. When we think about innovations, you're automatically going to think about therapeutic innovations. But I want to make sure everyone knows in healthcare, there's two types of innovations. The other innovation gets kind of lost sometimes, and it's what I do mostly, and so that's why it's important to me. So therapeutic innovations are things like egg freezing. They're new technologies that we develop that really help patients directly in their treatment. They give them better outcomes than they've ever had in the past. Amazing. In order for patients to actually receive those treatments, there is an area of study called care delivery innovations. In care delivery innovations, it's the study of and the practice of figuring out how to operationalize those advancements so that more patients can receive them, and they can receive them in a way that's actually feasible. If egg freezing takes 4 years, and if it takes 4 months, and in order for patients to be linked with the providers, it takes 4 weeks, that's not feasible. And so there are care delivery innovations. For example, the Oncofertility program, which we just started, it provides a nurse navigator where the oncologist can simply put in a referral. The nurse navigator will call the patient within 24 hours, speak to them, their loved ones, and courier them. First of all, have the sophisticated conversation, and then courier them through the process to make it as efficient as possible. This takes a dramatic collaboration with the fertility team, with the radiation oncologist, the oncologist, and the nurse navigator guides the patients through that. So that's a care delivery innovation. Otherwise, the prepubertal So before a boy goes into puberty, the testicular tissue cryopreservation, this is novel. This is still under clinical trials. And that is something that we're engaging in that you can only get one other place in the country, and that's University of Pittsburgh. The other is, of course, is the uterine transposition procedure, which our team performs. There's been less than 20 of these done in the world, and we've done them here at NYU, which is pretty remarkable.
Absolutely. And on the topic of collaborative care, NYU Langone has pioneered this integrated care model where doctors work together to create a personalized and comprehensive treatment plan. So what other women's health specialists do you collaborate with, and how does this type of approach really benefit patients seeking both fertility and oncofertility treatments?
So before we help someone get pregnant, if they have medical issues or problems, they meet with the high-risk OBs for a plan so that we're not doing disaster planning. They know what their pregnancy is going to be like. They know what's going to happen if things go wrong and who's going to help them. Many of them are referred by their, internists, rheumatologists, hematologists, and they coordinate care with us so we can safely get their eggs and make embryos so that when they're pregnant, they can go on. So it's really a team sport here, and it's great because NYU is a team place. The doctors here are curious, they're intellectual, they want to help, they enjoy the process, and that's what's unique.
I'll echo that. Teamwork makes the dream work. Collaboration, it's really where you see the magic happen, which you can't achieve by yourself. And I think it's a perfect augmentation of the name Mignone Women's Health. But in terms of women's health specialists, I would say, every day, if a patient comes in and they're pregnant with cancer, you're working with the high-risk specialist. For oncofertility, I've already mentioned to you, there's a host of different cancer specialists that are involved. I would include in that, partnering with patients and people who give philanthropic donations for research and care delivery innovation, like the Mignone family and others, of course. That is also a collaboration that is critical for us to advance women's health. And I'm so grateful to the Mignone family and others who have taken that deliberate act and will impact the lives of patients here at NYU and beyond. And we're committed to see that through.
Yeah, and on that note about, continuing to care for patients and really making a difference, what do you hope to accomplish with future advances in treatment options? Basically, what's next on the fertility preservation frontier?
It's just advancing egg freezing technology and making it more efficient and safe and making it more accessible. There probably will be some, groundbreaking approach that will change the way we do it now, but it'll happen. But the future of our specialty really, and the future of our society depends on us helping women have babies when they can, when they want, with who they want, or if they want, because we're below zero population growth, and we need to respect that, and we need to create an environment that women can build their families at the best time and do the most important, amazing thing that we all do as human beings, keep our species going.